The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell again with Leading Age Michigan, and we welcome you to our Friday Safe and Calm webinar event. This past week in Lansing has been very busy, with both the governor and the Michigan Department of Health and Human Services issuing a number, let's say, of orders and directives. Because of that, we focused our agenda today on those changes, and we are rescheduling our planned discussion of the federal changes in the paid leave requirements to another date. So this morning, we are going to start with a very brief update on current movement of legislative bills, and then we will move directly on to the new orders. So let's jump right in and turn the presentation over to Dalton Herbal, our Director for Public Policy.
Good morning, everyone. As Deanna said, we're going to have a brief legislative update today. For those of you who are on the SNF listserv, you will know that the budget was signed late Wednesday night after we had our discussion. So this means those funds to extend the $2 direct care bonus pay program for 3 months are in place. So you can keep on trucking on that front. The other big fund in there for providers to be aware of is that there will be $20 million in reimbursement for SNF providers for their PPE costs. This will be on a per bed basis, just taking the total number of beds in the state, dividing 20 million by that, that will be sent to you if you are a SNF provider by the end of October. After Thursday, that marked the last day that the legislature plans to be in session until after the election. I have been hearing that the Senate has been considering holding their committee hearings since they're not, the state Senate at least, is not up for re-election in this election cycle. But that would be kind of a unique situation. It rarely happens. So we'll see if they still hold true. So I'm going to provide a couple of updates on where bills are right now. So we'll know where they will be starting when they come back in session. So the electronic monitoring device bill that we discussed on Wednesday's webinar passed the Senate unanimously and is now moved over to the House, and that was in House Health Policy. The PACE bill that we discussed on Wednesday's call is still in that Senate Health Policy Committee, and that's the first committee it's in, so it's still there. And the bill for provider civil liability protections has passed the House and is on the schedule for the Senate Health Policy Committee and is just waiting for a hearing. That bill does apply retroactively, so even if they pass it, it'll then cover the dates that the bill specifies. So that's kind of where we stand right now in the state. And with that, we'll be moving on to the more content-heavy part of today's call.
All right, thank you very much for that, Dalton. Before we switch topics, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. All right, so now we can move on, Deanna.
Okay, so let's move on to Executive Order 2020-191. This order extends protections for residents and staff. It currently has no expiration date. The first section is about pretty much the same thing as its predecessor, 2020-179. It is an extension of 179, and we originally called that the Regional Hub Order, but there are some significant changes here. But again, a lot of the order remains the same. So there are still restrictions on evictions or involuntary discharges for non-payment during the epidemic. And the language is also still here about denying resident access to the facility. We've never been quite sure what scenario that was supposed to represent, but at any rate, it is still there. from the beginning, there was some fear on the side of the administration that nursing homes and other entities wouldn't accept hospital admissions without a negative COVID test, and that would create some havoc in hospitals during the pandemic. So the rule about requiring testing has been present, or not requiring testing has been present since this order first came out. However, there are protocols also about hospitals testing, and of course, nursing homes now must test on admission if the hospital hasn't. Along with that, there were some fears that if residents did not want to remain in a congregate setting during the pandemic and wanted to move somewhere else or to home, they might not be accepted back. And if there is capacity, facilities must take these residents back, and that has been in the order all along. Telemedicine is still encouraged. And of course, there is reference in this guidance in terms of the expectations when dealing with positive staff members. And it also references Executive Order 172, and that's where the employer responsibilities in terms of how to consider someone off work during these times when they could be potentially positive. The rules are all in 172, but none of those pieces are new. So the changes to the guidance start in Section 2, and one of the big ones is the change from prohibiting communal dining and group activities to limiting them. So there are limitations on dining and internal, external group activities based on what they're calling CMS and MDHHS guidance. At first we thought that this was, or at least I did, I just thought this was opening the door for an updated guidance from MDHHS on group kinds of activities. However, it was confirmed in a call yesterday with the department that essentially there is no MDHHS guidance for these communal kinds of activities, and that facilities should go ahead and follow the CMS rules. So we would refer everyone to the most recent CMS communication on dining and activities, and that would be in QSO 20-39-NH. And we are going to review that, at least for communal activities, a little bit later this morning. No changes to the need to provide PPE, hand sanitizer, and of course, cleaning and disinfecting. We do want to remind nursing homes that we continue to see citations for not using cleaning materials as the manufacturer recommends, especially for the timing for chemicals to be in contact with the surfaces. So that's an important piece to remember, and also make sure that your cleaning products have been approved by the appropriate agency. There are changes, though, with the communication requirements, and this has been really a focus of guidance from all sources recently. Employees need to be informed within 12 hours of any confirmed COVID positive resident or case, and the guidance also requires that legal guardians and residents, families, etc., need to be informed as well. Notices must be posted near the main entrance indicating the presence of a confirmed positive, and this must be displayed for 14 days after the last case positive. So during the time of any potential exposure, you must post these signs near the entrance, and most of you at this point have dedicated entrances. Someone suggested yesterday that perhaps dating that sign would not be a bad idea, but it's not required. You need to have policies and procedures to inform any prospective resident and staff of any confirmed cases, and you have to use those protocols and keep them in place for at least 14 days after the last positive case, which again is the time of potential infection and transmission risk. And you must support any contact tracing efforts. This is a new item as well. We're not sure why this was added specifically. If there are some issues with contact tracing, I'm not sure what they are. Generally, when there's areas of high transmission, the CDC doesn't think contact tracing is very helpful. But on Wednesday, if you remember, Margaret Chamberlain did note during our webinar that there had been a lot of issues with this recently with the Ohio surveyors. So at any rate, you should be looking at contacts when you identify a positive person and work with your local health department as well. Notifying employees of any CDC updates, that's not new. Reporting is still required by this executive order for all 4 entity types covered under it, which would mean nursing homes, adult foster care, homes for the aged, and unlicensed assisted living. Although there's some additional information about that from the department that came out at the same time as this order. So we will discuss that a little bit later in the webinar before we end. Reporting, of course, must be made to the local health department within 24 hours of identification of any positive cases. And of course, you have to transfer anyone who's medically unstable to the hospital. Those pieces are not new. So nursing homes are still required to make all reasonable efforts to create a COVID dedicated unit. And what is difficult here is that, you know, they don't talk about the need for a separate observation unit, but of course a nursing home has to have one if it's taking admissions or has persons who are potentially been exposed or suspected of COVID. At any rate, although they want each nursing home to have a dedicated unit, they only want you to do that if you can resource it and staff it and carry out strict infection control. So note that although there was language in the original order to include non-nursing home settings here, that had been discontinued months ago. And so this section only applies to nursing homes. It doesn't mean that those other settings can't have a dedicated unit. It means that nursing homes are required to make an effort to have one. So for all facilities, dedicated units are the first choice for placement of any positive resident. Otherwise, you must attempt to transfer the resident to what is now known as a care and recovery center, the new name for regional hubs, or an alternate facility with capability and capacity, or an available swing bed. And although there is an initiative to allow hospitals to have swing beds outside of the normal rules for that, I don't think there's a whole lot in development right now, so that might not be a very meaningful help there. The last resort is always the hospital, and we all know that if the resident is not in need of acute care, that option is not really real. Hospital discharges pretty much have the same options. The first being a care and recovery center. The resident can always go back to the originating facility, an alternate facility with, again, capability and capacity, or a swing bed. The requirement that hospitals provide a safe discharge destination is still in place during the pandemic, and if they cannot find an acceptable place, they must remain in the hospital until they can do so. There wasn't any changes to the need to communicate any advanced directives. There are waived regulations through the blanket 1135 waivers, I believe, and the state about notifying residents and families about transfers during the pandemic. But at the very least, under this order, you must inform everyone within 24 hours. And of course, if you do need to transfer someone for COVID care outside of your facility, you need to document the emergent need for that transfer for the safety of either that resident or the rest of your residents within your medical record, if you're a nursing home at least. We noted with this updated order that there were changes to some of the definitions. AFCs, HFAs, nursing homes are all defined the same way as they're in statute. Long-term care facilities are still defined as 4 separate kinds of entities. nursing homes, adult foster care, homes for the aged, and assisted living. They finally, though, defined assisted living as providers of residential care for at least 3 senior adults who need assistance with services, and those services are available 24 hours a day. So that's a bit clearer in some respects. And of course, they defined the care and recovery center to include the current regional hub centers during the transition to the new models and the new program requirements. So the governor's task force made recommendations that these regional hub centers have to reapply in order to continue their status. But the department needed to keep these regional hub centers open through this transition. So they're kind of grandfathering them in for a while, but my understanding is the ultimate requirement will be to meet the new standards for care and recovery centers, and that if some of these regional hub centers cannot, they will eventually be going away. So let's take a few questions.
All right, thank you very much, Deanna. Before we get to the questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association, but your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. Looks like we just have a couple questions right now. So the first is, since Executive Order 191 allows communal dining and activities consistent with CMS and MDHHS guidance, and MDHHS is silent on this, we should be safe following CMS guidance, correct?
That is correct, and that's what I clearly heard yesterday from the department. And immediately after this question period, we're going to go through CMS, actually it's QSL 2039 NH to review those requirements.
Okay. Do we yet know what CRC have been approved for admission?
No, and in fact, that's something we are going to go through the CRC requirements. I think that one of the concerns here is that the requirements have appropriately been raised to ensure that facilities that can actually meet the needs for some of these residents they can be met. But there is concern about whether or not some of the better facilities are going to want to do that. And so that's a hard discussion, but to my knowledge, there have been none designated. There is an application process, and I think that they'll probably be putting out more about that, the application process itself, in the near future. But the guidance is rather detailed, so we will go through that in a bit. But the simple answer is no. I do not know of any that have been identified to date.
With the EO 2020-191 and the elimination of independent living from the definition of LTCF, are they no longer under any of the rules that apply to LTCFs?
Okay, this has always been a point of confusion. Independent living facilities have never been included in all of the iterations of what we have called the regional hub order. I think it started out with EO 50, and then of course it has been extended numerous times. I think the last one was it 179? And forgive me if I get the number wrong, I do sometimes, but now it's 191. Long-term care facilities in that order never included independent living. The only order that was specific to independent living, and I think it's 174, but don't quote me, is the one that disallows visitation and requires a screening. So that is still, unfortunately, in effect. for independent living and all of the other facility types as well. One of the, just to give you a brief update on the visitation issues, my understanding is that the department is still waiting for a response from CMS in regard to their request for clarification. Supposedly, from Laura, we heard that they are expecting that response any day. But MDHHS did tell us yesterday that they fully understand, even though I feel that it felt like they're reluctant to open visitation because they're worried about an outbreak. They fully understand that outdoor visitation is almost meaningless in the near future because of the weather, and that they are going to have to look at some options. But they have not really completed any communication or discussion with CMS yet.
Okay. Are we supposed to follow CMS guidelines for communal dining and gathering, but not for indoor visits?
That's correct. The guidance is only for communal dining and group activities.
All right, sounds good. It looks like that was the last question, so we can go ahead and move on.
Okay. So we're going to go ahead and take a few minutes and review QSO 2039 and H, where there are some, it's not very detailed, but some criteria for communal dining and group activities as referenced in Executive Order 191. So one of the important things is that CMS states clearly at the beginning of their discussion about communal dining that in order to initiate these activities, CMS requires that facilities maintain compliance with the core principles of infection prevention. Now, there's nothing really different in this list of requirements: screening, hand hygiene, face coverings, social distancing, instructional signage, visitor education, cleaning and disinfecting, PPE, effective cohorting. I don't know how you would ensure that your cohorting was effective, but I would assume that means it meets all their requirements. And of course, last but not least, resident and staff testing. But these are things that you have to do anyway. I mean, so I don't know anyone who would, in other words, these are not additional requirements for communal activities, but these are required of each facility every day. So, but the guidance from CMS clearly states that these must be in place before you can open up communal activities and dining. So, what does the actual guidance say? Pretty much, residents can eat in the same room with a 6-foot social distancing. And they do ask facilities to consider whether or not, based on what's going on in your facility and perhaps the external community in terms of transmission, whether or not it's feasible or I would think appropriate to open up these to some communal dining and activities. So it's based on what's going on in terms of transmission and how things are going inside your facility, and I would be looking at outside transmission as well. Group activities can only be allowed for those who do not have active COVID or are not in observation or suspected to have COVID, obviously. And of course, all of that has to be with social distancing, hand hygiene, and face coverings. And they have some examples of some basic activities that, you know, we would likely see in nursing homes and other facilities that might suit, and they are listed here. So while these are obviously good for residents and sometimes the facility, communal dining can cause some challenges if you have to maintain all of the social distancing and other restrictions. It's possible you might have to extend your dining hours, your staffing, because you can't put everyone, depending on your space, perhaps in the dining room or in other activity rooms at the same time. So one of our members asked about what the best practices might be and how to get around some of those challenges. So we thought we would take a few minutes this morning and elicit from you all how you might be planning for this and what you might consider best practices to make this work. Even though this is relatively new technically, we do know that some members have experience with this because they were doing some of this social distancing in the dining room and other activities early in the pandemic. So before we get started and have a moment to ask these questions, take a moment to ask these questions, we want to note that CMS guidance says you may open these activities. It doesn't say you have to if it doesn't work for you, but then again, considering all of the needs and the visitor, not the visitors, but the residents' wants, it might be hard not to do that. So we're not looking for questions now, but are there any comments? First, about the challenges that opening up communal dining or group activities might present, and if so, please comment in the chat box. We'll give you a few moments to do that.
All right, we just had one come through. We are permitting dining one time per week in the dining room in a group of 40. We are also using these groups for programming purposes to control size and exposure and ability to shut down a group.
I'm sorry, Blake. I kind of lost you at the end there.
I'll just reread it. It said, we are permitting dining one time per week in the dining room in a group of 40. We are also using these groups for programming purposes to control size and exposure and ability to shut down a group.
So basically you're rotating people who can eat in the dining room, more or less, is what I'm hearing. Any other comments?
We are creating assigned meal times and combined tables to make them bigger.
Oh, okay, that's a good idea.
Starting with dinner only, hoping to add in breakfast and lunch service over the next few weeks. We plan to extend dining hours, have multiple dining venues, and limit the number of residents seated at one time. Someone says communal dining under these precautions will undoubtedly create added expenses as it will create duplicate or triplicate processes.
Right, right. And that was the concern that I heard from our member. So if you have to expand your hours, you have to expand your perhaps staff coverage, et cetera, in the dining room. So that might be a challenge, as we talked about. Anything else?
I'm not seeing anything. Did you want me to write these ones down in the document that I send you as well?
Yes, please write them down in the document that you sent me at the end of the session. Thanks, Dawn.
We have individual small tables spread with chairs spread out at least 6 feet apart. We have been doing every meal one person per table that are at least 6 feet apart. We will be extending dining hours and creating different seatings, assigning residents to a specific meal time. It looks like that's all I have right now.
Okay, well, I think what I'm hearing, the major trend is that you don't have to have all your residents eating every meal in, this socially distanced dining room. You can stagger the meal times to some degree. You can stagger which residents attend. They could attend just perhaps one meal a day. And I think there's a lot of options here. So thank you very much, everyone. We always appreciate your input. Let's move on to the new regional hub or care and recovery center guidance. So MSA 2066, I think, is now called the Policy for Care and Recovery Centers to Treat COVID Patients and Residents Requiring Nursing Facility Care. And in that policy, that's an important piece to understand because anyone in a care and recovery center, or what's now called a CRC, really must need nursing home care. So if they don't need nursing home care, it's really hard. If they only need isolation, it's going to be really hard to use those for that opportunity. So the simple need to quarantine someone will not be enough. And there are still challenges for other level clinics who might not be able to quarantine a person very well, and certainly couldn't put together a dedicated unit. So this policy was issued Wednesday with immediate effect, but there is still a comment period. They still have to have a comment period, even though the normal process is to put out a proposed policy first, but they do have the ability to make it immediate, and this policy is. The goal for these centers hasn't really changed, and this was a point of a lot of conversation a week ago with the department. Primarily, really, it is to provide a place to move hospital patients who might be difficult to place, who are COVID positive, obviously, or secondarily, to take residents from other nursing homes who cannot serve them. So it's really to ensure that there's surge capacity in case we have a second wave. But it is also meant to ensure that there are some safe options for senior residents as well. But when you move outside the nursing home, it gets to be hard to do that, not just because of the guidance as it's written, but because of some of the logistics about payment and level of care as well. So as we discussed, I'm sorry, can you move it back? I think there's more of there, thank you. As we discussed in the task force report and other issues with the department during development of this revised policy, we were very fortunate to get a lot of our issues addressed. There are more formal requirements for facility structure. There's definitely improved criteria for participation, which was one of our concerns from the beginning, was that some of these facilities really didn't meet what we would call a high standard of care. The draft for this guidance included a minimum star rating for staffing of 2, which is really hard for us to comprehend since staffing is the only area so far where research has definitely shown a direct correlation between the number of staff and the spread of COVID within a facility. So we would at least expect a star rating of 3, which is only average, and they have included that here. Some other obvious things is you can't be under a DPNA, and you also can't be what they call a red hand facility, which what they mean by that is the abuse icon can't be, you can't be currently under that. So the goal is to establish at least one facility in each of the 8 emergency preparedness regions. And as we noted earlier, the facility must have structures that work physically, physical structures for a dedicated unit, along with dedicated staffing. They now have to have a qualified infection preventionist who has completed the entire CDC infection control preventionist training. And that's like 26 or 28 modules, I think, quite a bit of work there. They have to have a staffing plan, staff training plan, and an adequate supply of PPE, but the state's going to help them with PPE as well. So that's probably not quite as critical in terms of a qualification. And there are some additional requirements in terms of their compliance with testing and results, a plan for complying with testing in the future. They want to know what their plan and history has been with screening procedures for anyone coming in and out of the facility. They also are requiring a communication plan, and that's intended both for residents and family, but also a communication plan for referral sources. And of course, the use of virtual visitation, because obviously there's not going to be any visitation here in a COVID unit. They're going to first do a desk review and ensure that any applicant meets the criteria. Depending on the transmission risk around in the community and perhaps in the facility, depending on how things are going, they are expected to do an on-site visit to confirm facility performance. But if there's a lot of risk of infection, they may make that virtual. We encourage them to actually have an on-site visit. You can move on. Oh, right, and there's no appeal rights. The state is going to decide themselves whether or not a facility would meet the criteria or not. So the program, as we talked about earlier, is still designed for hospitals and nursing homes only. Well, primarily, let's say primarily. There is new guidance that hospitals should try to keep residents who are COVID positive in their facility if there is only 3 days or so left in the isolation period. And if you think about it, it makes little sense to transfer someone out to a care and recovery center for that short of time, unless it's absolutely necessary, because you're going to be transferring them back somewhere else very shortly. And that should limit some of the transfers of these positive persons even to their originating facility, if indeed the hospitals do that. They will take referrals for persons from nursing facilities when those nursing facilities cannot provide care and the resident needs a nursing home level of care. And that's part of the difficulty. Isolation needs alone won't do it. So after a lot of discussion with them, they did finally agree to at least consider admissions from other facilities, such as HFAs and AFCs, on a case-by-case basis. And we've talked to them several times about the fact that there is a gap for persons who need to be served and are currently in an assisted living level kind of care site without adequate resources to serve them. But there are still those challenges that I discussed earlier. There are payment issues, level of care issues that can complicate such transfers. So there's still some challenges to serving these COVID positive persons in non-nursing home settings, but the state has agreed to at least look at some of these problematic cases on a case-by-case basis and can use the Care and Recovery Center if they can make it work out. So we've listed the discharge criteria here. It's not really anything new or different or anything that you wouldn't already expect. The policy also addresses the need for state oversight and consultation, weekly monitoring calls. The state will assist with technical assistance and PPE. And of course, there's a rather detailed process for deactivating a care and recovery center within the guidance, but we're not going to review that here. So those are the requirements for the CRCs. And also this week, HFAs and AFCs got an update about reporting. So the Executive Order 191 that we just went through earlier, it continues the requirement for long-term care facilities to report data directly to MDHHS, just like nursing homes have to, although they use a different system. But late Wednesday, the state terminated reporting for these entities, at least for the time being. We believe that there were always some difficulties with unlicensed assisted living reporting. and they are reviewing their entire system for that. It looks like HFAs and AFCs will resume reporting in the future when the state figures out how to deal with that. It's not so clear about unlicensed assisted living. They may not be required to report in the future. And part of the difficulty with that is that no one's 100% sure, since they're unlicensed, who they are and where they are. But HFAs and AFCs can expect some notices about resuming, I would think, shortly. And of course, the state always wants to identify that all facilities, no matter where you are on the continuum of care, you have to continue to report any positive cases to the local health department. So that's pretty much what we have today. Any questions?
All right, thank you, Deanna. We do have a few questions, so I will just hop right into those. If we are in ALHFA, we still do not follow the QSO to permit indoor visits. We are only to follow for communal activities and dining, correct?
That is correct. Visitation is still not allowed in any of these facilities, from independent living all the way up to nursing home.
All right. Residents that share a room, would they be allowed to dine at the same table, or would they still be required to eat socially distanced at a separate table?
They have to be socially distanced, and they need to be socially distanced when they're in their room as well.
Okay. The discrepancy between MDHHS and CMS still is in place?
Yes, it's definitely in place. I spoke about this a little bit earlier, but we're hoping for some finalization of this soon. I do know that Larry Horvath told us earlier this week that a response from CMS about the department's request for clarification is expected any day, really. We're not sure exactly what the state does expect. We do know that they're reluctant to open up visitation, but we think it's got to be just a matter of time. One of the things is that Michigan has lower overall county transmission rates than a lot of other states. So I think they'd be hard-pressed to say that Michigan can't open up visitation in nursing homes when other states with higher transmission levels will be doing that. And of course, it's really hard to justify continuing isolation for these poor seniors for the foreseeable future. That's just can't be fathomed. So, as I said earlier, the department did identify on a call with them, I guess it was yesterday, that indeed they do understand that outdoor visitation isn't going to be feasible much longer, and that they would be looking at that. But nothing in writing. There's nothing right now that has changed anything in terms of visitation.
Okay. As we consider opening dining, should we be looking at the EOs related to restaurants for guidance?
I don't think that those requirements would necessarily apply to you. However, if you were looking for best practices, you might want to look at that. But if the guidance for restaurants, and I've glanced at it once or twice, I really can't tell you what those requirements are. But if they are less restrictive than what CMS is saying, you're going to have to go with the CMS guidance. Always remember that. CMS is the guide that you must meet. And there are other guidance that could perhaps extend what CMS says, but you can't violate a CMS guidance through any other kind of regulation.
Okay. QSO-20-39 states staff and resident testing is required to proceed with opening communal dining and activities. However, HFAs are not required to test, so can HFAs still proceed with progressing communal dining and activities?
Off the top of my head, I would have said yes. I do believe that the intention of the department was to simply put out the protocol, to identify the CMS protocol for communal dining and activities. And yesterday, that never came up about whether or not HFAs and other entities would have to test in order to do that. Off the top of my head, I would say that if that were the case, we would have heard about that. But that's a question that we will forward to the state.
All right, thank you, Deanna. As of right now, it looks like that was our last question. So if anything pops up in your head after the webinar concludes, feel free to email Dalton, Deanna, or the Safe and Calm webinar, and we will make sure that we get that answered for you. Other than that, we would just like to thank Deanna and Dalton and the 80 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I hope everyone has a great remainder of their Friday and enjoys their weekend. Other than that, I think that is it. Deanna or Dalton, do you have anything else you'd like to say?
I do want to remind everyone, first of all, have a great weekend, everyone. It's been a really, it's been a difficult and time, really. But I also want to remind everyone that there is no webinar next Wednesday. And we will pick up our next webinar on Friday, October 9th at 11 a.m. I'm sure we'll have a lot to talk about because, you know, the state moves pretty quickly these days. So, so thank you, everyone. Dalton, anything?
No, just have a good weekend.
All right. Thank you, everyone, and we will
Take
see
care,
you next
everyone.
week.
Take care.